We know that a number of new lung cancer patients often have biomarkers done in order to direct their initial therapy. And I think when I last checked the National Comprehensive Cancer Network guidelines and about the importance of tumor testing, there were about 11 specific targeted mutations with specific therapy recommendations, both for first and second line options, as well as the addition of immunotherapy markers like PD-1 and PD-L1. Can you speak to the significance of these biomarkers when it comes to decisions around therapies? And in my readings, I came across things such as the tumor mutational burden or circulating tumor DNA. Do you use those in your practice to help categorize patients?
Yeah, this is really a critical thing because this concept of reflex testing or these assays, this molecular or biological characterization of the tumor being done automatically once a biopsy is generated is just not pervasive worldwide, right? I know for a fact in the US, there are a lot of places that don't have access to this,
Exactly.
particularly for early stage patients. Now, it's vitally important. There's a paper that came out actually from the metastatic setting that was retrospective, but it did show that patients who had next generation sequencing and molecular data prior to initiation of their systemic therapy had better overall survival than those who did not have that information available. And that makes a lot of sense because not all lung cancers are created equal and not all of them will respond to the same types of treatments. And sometimes exposing them to one type of treatment might cause the next one, which is the correct one that they should have been on in the first place, to be more toxic as a result of the interactions with that prior exposure. So when I work in Quebec, okay, it's a publicly funded healthcare system, certainly not as fortunate as a lot of places around the US, and delays are significant. But I always try to explain to the patient that I understand the urgency to get to treatment, but the real urgency is to get to the right treatment, and that time spent to get the necessary information to adjudicate the correct treatment is vitally important. And in early stage, we've talked about immunotherapy as this new and exciting option that improves survival, but it's not the only innovation. We have the ADORA trial, which offers the opportunity for patients to get post-operative targeted therapy in the context of lung cancers that have mutations in the EGFR gene, and that is associated with a very important overall survival benefit. There's the ALINA trial that was presented at ESMO that shows very important benefits in terms of disease-free survival when patients get access to targeted therapy for the ALK alteration that can be present in a fair number of lung cancers. And all of these interact quite poorly with immunotherapy. And by the way, if you have one of these mutations, you tend not to respond well to immunotherapy. So you can easily expose yourself to all of the risks and basically waste a bunch of time and energy and incur risk by embarking on a treatment that's not well suited to your tumor. And so it is vitally important to have that information. And with respect to the PD-L1, it is important to have it so that you understand the likelihood of response and how the treatment might potentially benefit or not that patient. I don't really use it as a decision tree, the PD-L1, because I see benefit across all the strata, just not the same magnitude of benefit. But it is still valuable. It is informative to guide patient care. With regards to TMB and T cell infiltration and a whole bunch of other biomarkers, I don't think they're as well validated, to be honest. We probably need to build better data sets on those, especially in the early stage. And there's significant cost to generating some of these biomarkers, so we have to be mindful of that. So I think for the time being, assessing at a bare minimum EGFR status, ALK status, and PD-L1, that's the bare minimum. But these other gene targets are important because there are other genes that, when mutated and driving the lung cancer, we know that immunotherapy is not a great option. You may choose a different path for those patients.
Exactly.
So a lot to consider.
Yeah. No, I mean your perspective in this is great because we know the changing landscape of lung cancer treatment over the last 10, 15 years has been significant with the mutation targets, the PD-L1 markers, and certainly now the advancements in the kind of surgery and adjuvant therapy. So where do you think, as a surgeon, lung cancer therapy is going over the next few years? What do you expect to see, or what do you hope to see with regard to treatment options?
Well, like we've said it's super exciting for us as clinicians to see all these opportunities emerge. For patients, it's just as distressing as ever to receive the diagnosis and have to deal with all of the unknowns. Where are we going? We're just heading into a cloud of complexity where we have a ton of options that will emerge. We have the challenge of lung cancer becoming, it's one of the most commonly diagnosed cancers. It's the highest cause of lethality amongst all cancers, but it is a collection of rare diseases. And getting appropriate comparisons of the available therapeutic options in each of those distinct biological categories is going to be a massive challenge to do, and will require global cooperation. But for me, the destination and what I find most exciting is what's come out of some of these trials. When a patient gets a complete pathological response to chemoimmunotherapy, their overall survival, right now we have 3-year data, but like I said, it'll mature. 95% of them are alive. So if you apply the right systemic treatment and you're able to eradicate the cancer with that, and for now at least, we still need to confirm with surgery, that is extremely good news for the patient.
Right.
It can de-escalate the surveillance to some extent, reassures them that they're not living with a blade over their head, that the cancer is going to come back because the statistics are so promising. And in my mind, I do some science and stuff. This is the goal. This is what we need to be targeting. We need to think of this almost in the same terms as we think of treating pneumonia. You get a culture, what the response to an antibiotic that bug has, and you give them the treatment until you don't see a pneumonia in the lung anymore. And it could be imaginable where we're treating some early stage lung cancers in that fashion, and then not having to expose patients to the morbidities of some of the local treatments that exist for them. So I think it'll be a rapidly shifting landscape with tons of good opportunities for patients.
Yeah, I mean, you basically are saying that precision medicine, again, overused term, but it's exactly what we want to do, is the right drug at the right time for the right patient. So that's great.